Hello, welcome to the 6th lecture of the course. Today we are going to discuss monitoring, supervision, and assessment of intimate partner violence, IPV, and problematic substance use, PSU, services. Every treatment program, whether for IPV or PSU, should have an established protocol regarding monitoring, supervision, and assessment of the services provided. For programs addressing women survivors of IPV, women with PSU issues, or women with co-occurring IPV and PSU, monitoring should follow the basic principles and ethics that were mentioned in the first lecture. For the clients, these principles must include autonomy, safety, and respect for their interests and their rights. For the professionals, these principles include empathy, flexibility, ingenuity, confidentiality, justice, non-maleficence, self-knowledge, and self-improvement. Moreover, professionals should be familiar with the counseling procedure, its promotion, and facilitation, including assessing clients' suitability for IPV and PSU counseling. At the same time, IPV and PSU services should have clear protocols that define, among other things, how these principles are applied. When managing therapeutic relationships, professionals should be aware of and frequently reflect upon their prejudices, attitudes, beliefs, and emotions regarding the boundaries and rules of each therapeutic relationship. Like principles and ethics, these boundaries and rules should also be determined by the IPV and PSU services philosophy, protocols, and policies. Professionals should be aware of their skills and knowledge pertaining to communication, counseling, attention, active listening, risk assessment, and crisis management. It is also important for professionals to be committed to constantly developing those skills. IPV and PSU services should enhance professionals' motivation and provide them with opportunities to further improve their skills. Specialized and evidence-based trainings that follow advancements in research and develop professional skills pertaining to co-occurring IPV and PSU should take place on a regular basis. At the same time, such trainings should also consider professionals' needs. These needs constantly arise and change because the phenomena of IPV and PSU do not remain the same over time. To achieve smooth operation of IPV and/or PSU services, each agency should have clear operating regulations that underline the following 4 aspects of their work. Number 1, the philosophy or ideology followed by the IPV or PSU agencies. This determines the perspectives from which professionals perceive IPV and PSU issues. Number 2, approaches for people who suffer from IPV and PSU issues. As mentioned in Lecture 3, services should follow very clear and specific approaches regarding interventions for IPV, PSU, and co-occurring IPV and PSU. These approaches should be gender-sensitive, feminist, trauma-informed, and person-centered. Additional efforts are required to implement comprehensive, holistic, and integrated models that simultaneously address IPV and PSU, as at the moment, this seems to not be the case in most relevant agencies. Number 3, staff of the organizations working in the field. Agencies should provide professionals with adequate knowledge and training and focus on professionals' satisfaction with their work, as this directly affects the quality and outcomes of the services they provide. Number 4, extroversion. This is related to multi-agency cooperation and community interactions that enable communication, dissemination, and collaboration through creating local strategic partnerships and developing integrated commissioning strategies, care, and referral pathways. These regulations, as well as their implementation, should be monitored on a regular basis following specific guidelines and policies defined by each agency. Professional supervision is a crucial part of counselors' professional and personal ethics. It should be provided by the corresponding services and could be either internal or external. Professionals should be committed to supervision and make every effort to have it if it is not already provided by the agency they work with. Supervision has multiple personal, professional, and organizational benefits. It enables counselors to be aware of their strengths, skills, and abilities, as well as their vulnerabilities, weaknesses, and blind spots. At the personal level, supervision fosters self-knowledge and self-improvement, while at the professional level, it fosters awareness, empathy, and therefore efficacy. At the organizational level, supervision highlights professional needs and gaps and changes that are required in the system. Clinical supervision provides professionals with training, education, support, and guidance. At the same time, it creates a positive work environment for the entire staff. Supervision models for mental health professionals and services are diverse. They are usually based on observation, assistance, and feedback. Consequently, each professional or organization can choose the supervision model that fits their philosophy, strengths, needs, and the approach or model for treatment that they practice. Although the underlying theory of supervision models is extensive and deep, we will briefly present the basic characteristics of 3 categories of supervision models. The first category consists of psychotherapy-based supervision models, which simulate the therapy itself and are often perceived as a natural extension of it. According to Smith, this, quote, theoretical orientation informs the observation and selection of clinical data for discussion in supervision, as well as the meanings and relevance of those data, end quote. Psychotherapy-based supervision models include the psychodynamic approach to supervision, the feminist model of supervision, cognitive behavioral supervision, and person-centered supervision. In the next category, developmental models of supervision involve supporting the supervisee through progressive stages of development from novice to expert. Each stage consists of concrete characteristics and skills. A basic principle of developmental supervision models is that the supervisee's current stage must be accurately identified. The supervisor's role is to provide feedback and appropriate support to the supervisee based on their developmental stage. At the same time, the supervisor facilitates the supervisee to proceed to the next stage through interactive processes such as scaffolding, and to learn by taking advantage of existing knowledge and skills. Through this interaction, advanced critical thinking skills are developed for both parties. Developmental models of supervision include the Integrated Development Model and Runestad and Skovholz model. In the last category, integrative models of supervision incorporate more than one theory and multiple techniques. Given that most counselors practice integrative counseling, integrated models of supervision are quite widespread. Integration in such models is achieved through technical eclecticism and theoretical combination. The most prevalent integrative models are Bernard's discrimination model and the systems approach. There is, however, another classification of supervision models offered by the Substance Abuse and Mental Health Services Administration of the United States government's Department of Health and Human Services, or SAMHSA. They divide supervision models into the following categories. Competency-based models. These models consider a supervisee's skills and learning needs as a focal point of the supervision process. Thus, efforts are directed at formulating specific, measurable, attainable, realistic, and timely, or SMART, goals. Treatment-based models. These models train professionals in a particular theoretical approach to counseling in which evidence-based practices, such as motivational interviewing and cognitive behavioral therapy, are integrated in supervision. For this, they require adherence and adaptation to the corresponding theoretical model. Developmental approaches. These approaches are grounded in the acknowledgement that all therapists and counselors go through different stages of development. Movement through these developmental stages is believed to be nonlinear and is influenced by changes in the assignment, the setting, and the population served. Integrated models. These models integrate descriptive dimensions of supervision, such as cultural and diversity factors, with contextual and developmental aspects. Furthermore, they stipulate a distinct treatment model and include leadership styles. According to SAMHSA, regardless of the model of choice, supervision related to PSU should be governed by the following central principles. Clinical supervision should be considered an essential part of all clinical programs. Clinical supervision enhances staff retention and morale. Every clinician, regardless of their level of skill and experience, needs and has a right to clinical supervision. In addition, supervisors need and have a right to supervision of their supervision. Clinical supervision requires the full support of agency administrators. The supervisory relationship is the crucible in which ethical practice is developed and reinforced. Clinical supervision is a skill in and of itself that must be developed. Clinical supervision in PSU treatment most often requires balancing administrative and clinical supervision tasks. Culture and other contextual variables influence the supervision process. Supervisors need to continually strive for cultural competence. Supervisors have the responsibility to be gatekeepers for the profession. Clinical supervision should involve direct observation methods. Assessment of the treatment program is vital, as it provides quantitative and qualitative data regarding IPV and PSU services, results in a broad overview of the entire program, and adds dimensions of women's experiences, interests, and needs that may have been neglected. It leads to the implementation of more efficient, evidence-based interventions and the provision of high-quality services to women survivors of IPV with PSU issues. IPV and PSU agencies, as well as professionals working with them, should determine and enact specific criteria, indicators, and methodologies in order to evaluate and thus improve the quality of the services they provide. Such criteria and indicators should be both qualitative and quantitative to produce coherent and accurate results. According to Samartzis and Talias, these indicators can be divided into the following 7 dimensions of quality assessment. 1. Suitability of services. 2. Accessibility of services to patients. 3. Acceptance of services by patients. 4. Ability of healthcare professionals to provide services. 5. Continuity of service over time, ensuring therapeutic continuity. 6. Efficiency of healthcare professionals and services. And 7. Safety for patients and for healthcare professionals. The criteria, indicators, and methodology of the assessment mainly depend on the population to which each service is addressed. For example, women survivors of IPV, women with PSU issues, or women with co-occurring IPV and PSU, and the approach and model being followed. For example, gender-sensitive, feminist, trauma-informed, or integrated models. As a result, the assessment is closely related to the therapeutic goals and expected outcomes. For women survivors of IPV with PSU issues, the assessment should combine both practical experience and theoretical knowledge and be comprehensive, focused, and carefully planned to evaluate all aspects of clients' lives that may be related to or affected by IPV and PSU. That is it for today's lecture. Thank you for watching. In the next lecture, we are going to talk about multi-agency cooperation related to IPV and PSU. Goodbye.